Okay, so my name is Nathan Rono. Incoming level 5, and I'll be taking you through meningitis. So introduction. So meningitis is a devastating disease and remains a major public health challenge. So from the word meningitis, we are thinking of meninges and itis. So what is itis? You can type on the chat. When you hear the word itis, what does itis mean? Inflammation, yeah, right. Good. So we are thinking of inflammation of the meninges. Okay. Meningitis can be caused by many different pathogens, including viruses, fungi, but the highest global burden is seen in bacterial meningitis. Together with sepsis, meningitis is estimated to cause more deaths in children under 5 of age than malaria. So I think you're going to do income health, where you'll know that sepsis, malaria, HIV, maternal neonatal complications, they are the main causes of death in children under 5. And survivors can suffer severe sequelae with considerable social and economic costs. Okay, so that's just the introduction. So meninges, when you hear the word meninges, we know we have 3 layers, isn't it? We have the dura mater. Can you see my laser? Okay, so from the outermost layer, we have the dura, it is arachnoid, then the pia mater, it is, then the brain. Okay, so meninges are the outer covering of the brain. So when there is inflammation, is what we call meningitis. Definition: it is defined as an acute inflammation of the protective layer, the meninges, covering the brain and the spinal cord. Okay, so the meninges, they extend from the brain up to the spinal cord. The arachnoid and pia mater become inflamed and opaque, along with the first 2 layers of the cortex and the spinal cord. Many complications can result from the risk inflammation, such as increased risk of infections leading to blockage of cerebrospinal fluid flow, thrombosis in the cortical veins, and additional clinical symptoms. So we're going to look at all the complications of meningitis, but these are just the main as to mention. So as you can see, we have this is the brain. This is the brain. So this is the cross-section of the brain. Then from inside, we said it's dura, arachnoid, then pia. So this is the pia, arachnoid, then the dura. Okay. Okay. So there are types of meningitis. We can classify them in terms types of duration. Let's start with duration. So duration, as you'll see in IMED, is very, very important. So as you can see, like, let me ask you a question. When we say something is acute in terms of a symptom, let's say cough, what do you mean by acute cough? How many days or weeks do you think acute cough is? Just try and pick at random. Jacob, how long do you think is an acute cough?
Okay, I'd say 2 weeks.
2 weeks?
Yeah.
So it's actually 3, okay?
Okay, thanks.
Yeah. Then between 3 to 8, we call it subacute. Then greater than 8, that's chronic, okay? Let's go to another system. Let's talk about nephrology. When we're defining acute kidney disease or acute kidney injury, what is the time frame? Just try. Nuresha, what's the time frame for acute kidney disease?
A few days, like a week maybe?
No. So acute kidney disease is 3 months. Okay. Then chronic, if it's more than 3 months, we call it now chronic kidney disease. Okay. Let's define it in terms of liver injury. What is acute liver injury? Ian, in terms of days, months, weeks?
I'm not sure, but 3 to 6 months. I'm not really sure. Yeah.
Yeah, you're close. So 6 months. So acute is 6, chronic is more than 6. So as you can see, these definitions change in terms of the symptom and the disease. Okay. So for meningitis, acute life-threatening inflammation often caused by bacterial viral, which develops over the course of few hours to days. Okay. Then if it's over days to few weeks, it's subacute. Then chronic is at least 1 month without spontaneous resolution. Okay. Then we said the 3 most common etiologies of chronic meningitis, 3 broad categories. We have fungal, tuberculous, and autoimmune, and neoplastic. So neoplastic is if it's related to a tumor. Okay. So this is very important. They ask you these questions in Viva and MCQs. So you'd be asked, like, for example, this year we didn't have a Viva on meningitis, so it's most likely going to be in your year. They'll ask you, define meningitis based on duration. What are the most common? So if you're told based on duration, you'll say acute, subacute, and chronic. Based on etiology, you'll say bacterial, viral, fungal, parasitic, non-infectious. Then you'll be asked, okay, for bacterial, what are the main bacteria that cause meningitis like that, okay? So bacterial, it is the most severe form. Less common than viral. So we have Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza, Listeria monocytogenes, Staphylococcus aureus. For viral, it is the most common, but it is less severe. Coxsackie, Echovirus, West Nile influenza, HIV, measles, and herpes virus. Fungal, it is rare. Mostly occurs in people who are immunocompromised. For example, people who have HIV. Cryptococcus is the most common. You'll hear about it. Someone who has cryptococcus meningitis, cryptococcal meningitis. Then there's also blastomyces, histoplasma, and coccidioides. And then parasitic, this is less common, like as angiostrongylas. These ones are less common, so this is not that important. Then non-infectious, lupus, brain surgery, cancer. So why are we saying this? This is because when we reach to the clinical features, we should be thinking in the line of what is causing this meningitis, okay? So that's why we have to rule out bacterial. Is it a bacterial cause, a viral, fungal, parasitic, or non-infectious? Here are the risk factors. There are many, but I put the most common. So age, we have children younger than 5 years. Okay. Use of immunosuppressive drugs. So immunosuppressants. We also have chemotherapy, chronic malnutrition. So you're at a state of weak immune system. AIDS. So AIDS is stage 4 HIV. CSF shunt, chronic alcoholism, diabetes, and pneumonia. But if you have a question, you can just type on the chat, then I'm going to answer it. So as you can see here, chronic alcoholism and diabetes, they put you in an immunocompromised state. That's why you're at a risk factor of getting meningitis. Okay. Yeah. So I haven't put the etiology based on the ages, but what you should know is the most common cause in children around 1 month to around 2 years is strep pneumoniae. Okay. Then for the normal population, from 2 years to, let's say, 50 years, Neisseria meningitidis. Okay. The Neisseria meningitidis and strep pneumoniae, those are the 2 most common. And then the elderly, strep pneumoniae. Okay. Where will you see Staphylococcus aureus? For example, if you had a history of trauma, so penetrating trauma, like for example, a knife to the head, or something like that. We expect when you culture, you're going to find Staphylococcus aureus. Listeria monocytogenes, these are common in immunocompromised individuals. Okay. Pyogenic meningitis. So pyogenic meningitis is also called acute bacterial meningitis. Now, this is the most severe form and it's life-threatening, okay? Acute bacterial meningitis is rapidly developing inflammation of the meninges that cover the brain and spinal cord and of the fluid-filled space between the meninges, subarachnoid space, where it is caused by bacteria. Okay, so subarachnoid space is where CSF is found, so it flows. So infection causing meningitis arises in the nasopharynx. So how do you think, why do you think it arises from the nasopharynx? So how do you think it get to the meninges? I've seen someone has joined us. Debbie, how do you think it gets to the meninges from the nasopharynx? Hi, Debbie. Grace, Debbie is not here. Grace, how do you think it spreads from the nasopharynx to the meninges?
I'm not so sure, but is it in any way associated to the sinuses?
So continuous spread from the nose, eyes, then it reaches the brain. Then we have something called retrograde transport within the cranial nerves, okay? Prevalence. So prevalence is relevant since we want to know how bad this disease is. Bacterial meningitis appears more frequently in populations that are close in living quarter. You see, this is a very big risk factor. That's why when you're asking someone who you think has meningitis, you ask them the state of living. Do they live in an overcrowded place? Do they live in close contact with people? Okay. How is the relation with people? How many people do they live in that house? Okay. And if someone else has experienced a similar symptom like them. Okay. So don't ignore this. That's why we have to ask. Although the prevalence of meningitis has decreased, it is believed that many cases go unreported. The incidence of meningitis is 2 of 6 per 10,000 adults per year in developed countries and is 10 times higher in less developed countries, which is our country. Can develop in infants and children, particularly in geographic areas where children are not vaccinated. As people age, acute bacterial meningitis becomes more common. So this is quite true because I remember when I was clerking my meningitis case, the lady, she was around, I think, 20, 21. She got it from her child. So the child had a flu, and then she got the flu, and then it's, I think 3 days later or 4 days later, she came in with symptoms of meningitis. So unfortunately, it became encephalitis, but they were able to, it was resolved. If meningitis develops within the first 48 hours after birth, it's usually acquired from the mother. It may be transmitted from mother to newborn as the newborn passes through the birth canal. In these cases, meningitis is often part of serious bloodstream infection, which is sepsis. So etiology, as we had mentioned, in neonates, E. coli, Klebsiella, Haemophilus. Children, Haemophilus pneumococcus, which is strep pneumoniae, as I had said, is the most common. Then meningococcus. In adults, pneumococcus, meningococcus. And then others, Listeria monocytogenes. In the immunocompromised, Streptococcus pyogenes, Staphylococcus aureus. Infection with the mixed etiology, 2 or more bacteria may occur following head injury, mastoiditis, which is inflammation of the mastoid process, or iatrogenically after lumbar puncture. So it can be after lumbar puncture or recent brain surgery. So route of entry, spread through the bloodstream from an infection in another part of the body. So this is the most common route. Okay. So it can be through hematogenous spread, where the bacteria, let's say you have an infection like from the mouth, like for example, tonsillitis. So it spreads until it reaches the meninges. Spread from another infection in the head, such as sinusitis or an ear infection, after a wound penetrates the skull, or meninges caused by Staphylococcus aureus. Surgery is done on the brain when a shunt is placed in the brain to relieve the increased pressure in the skull. Then it becomes infected, especially in this disease. What do they call it? Hydrocephalus, yes. When bacteria enter through a birth defect in the skull or spine, so such as spina bifida, okay? Pathology. So causative organism enters into CSF through blood-brain barrier. What happens? A purulent exudate, most evident in the basal cisterns, extends throughout the subarachnoid space. So we're going to see this. So in cases where like we have a bacteria that has got into the CSF, you'll see it's very cloudy in appearance. The underlying brain becomes congested, edematous, and ischemic. The integrity of the pia mater normally protects against brain abscess formation. So let me explain using this. So we have bacteria, let's say, for example, strep pneumoniae, colonization and penetration of nasopharynx mucosal membranes by bacteria. Okay, so the bacteria is at the nasopharynx. It will survive in the blood, and then it is transported. Invasion of the central nervous system. So when it reaches the central nervous system, it passes through the blood-brain barrier, then it multiplies in the subarachnoid space where the CSF is. So leads to increased permeability of the blood-brain barrier. As you can see, this arrow, stimulation by bacteria and bacterial products. So we know that each bacteria has different ways of attacking this body. You remember the gram-negative bacteria and the gram-positive bacteria each had their ways of attacking. So for example, if they're using toxins, so some bacteria have toxins that are going to attack the system. Some use spores. You remember those ones when you did in microbiology. Then there'll be transendothelial migration of granulocytes and monocytes. So here the immune system has now started being active. There'll be release of cytokines and prostaglandins, which also increases the permeability of the blood-brain barrier, leading to more and more bacteria, then leakage of plasma proteins. So the end result is cerebral edema, increased intracranial pressure, and impaired circulation. So when it reaches here, it becomes a medical emergency, okay? Presentation. So this is what you have to remember. I've mentioned a lot of things, but now this is the most important, because if you don't know how a patient with meningitis presents, it's going to be useless. The classical clinical triad is fever, headache, and neck stiffness. Okay, so if a patient tells you, oh, I have a headache, it's usually occipital. It can be occipital or frontal, and then neck stiffness. So neck stiffness, one thing I have to mention is neck stiffness is an exam finding. So when reporting, we don't say the patient reports of neck stiffness. We say the patient reports pain on moving the neck or inability to rotate the neck or to move the neck. Okay, they will report of that. But basically, we know that it's stiff. So they're trying to move. If they want to move their head to one direction, they'll have to move their whole shoulder and to move like that because it's very stiff and painful. Prodromal features. So these are the features that come before. Okay. So a respiratory infection, otitis media, or pneumonia associated with the muscle pain. So as we said, you'll start with a flu. You don't know you have a flu. It goes, spreads, then it becomes meningitis. Okay. So you have to inquire what happened before you got the neck stiffness, headache, and fever. Okay. Meningitic symptoms. So severe frontal or occipital headache, stiff neck, and photophobia. So photophobia, they'll tell you exposure to light they don't want to be exposed. They don't want to be exposed to a room that has light, so they prefer to stay in the dark. Okay. Then systemic signs. Oh, one other thing. The worse it gets, if it progresses to encephalitis, we'll now start having. You can have features of increased intracranial pressure. I've spoken for a long time. Someone tell me, what are the features of increased intracranial pressure? Ian. Features of increased ICP.
So you'd have projectile vomiting and papilledema.
Okay, but okay, yes, it is, but will the patient tell you that? But yes, it is. On fundoscopy, you're going to see papilledema.
You'd have confusion.
Altered mental status, yes.
Yeah. Yeah, those are the answer. Headache.
Headache, yes. Yes, good. For neck stiffness, the wording is for PC, HPI, or both. So for neck stiffness, you can't put it at the HPI because we said HPI, we put words that the patient has told you. So you can say the patient reports a headache, you characterize the headache in terms of Socrates, then maybe you say it was associated with severe neck pain and inability to move the neck in any direction. So when the lecturer hears that, they know, okay, now you're talking about neck stiffness. Okay? Because the word neck stiffness is an exam signing. It's like saying edema. You never say edema. The patient can never tell you edema. They'll tell you leg swelling or lower limb swelling. Yeah. So high fever, transient purpuritic or petechial skin rash in meningococcal meningitis. So this is very specific for Neisseria meningitidis. It can come in a viva. You're told, oh, the patient came in with fever, headache, neck stiffness, and transient meaning temporary. Purpuric, so they're small dots, and petechiae, black dots that you're going to see. They are skin rashes. The patient had these skin rashes. Then you'll be asked, okay, what does the patient have? You say meningitis. Then you're asked, what is the bacteria or what is the etiology? You have to say Neisseria meningitidis. Very, very specific for Neisseria meningitidis. And then we have the meningitis signs. There are two. These ones you have to know. You must know these ones. When you're doing the CNS exam, as we are going to do tomorrow, I hope you'll avail yourselves. You're going to do these signs, Brudinsky and Koenig. So let me explain before I show you. So Brudinsky is caused by passive neck flexion, producing flexion of the hips or the knees. I think I have a picture. Yes. Now look at this child. The child lays flat. Then you tell them, flex this neck, or you flex for them. When you flex for them, you'll see this is the hip flexion. Okay, the hip and the knee will flex. The reason is when you flex the neck, remember here are the meninges, so you're flexing the meninges, and because they're feeling pain, they're going to flex their knees. Okay, so severe neck stiffness caused by patient's hips and knees to flex when the neck is flexed. Another one is Koenig's. Koenig's sign presents as restrictive passive extension of the knee while the hip is flexed. So what you do is the child is laying like this. You tell them to raise their leg. Then you flex. So this is the, what is this? The thigh and then the leg. Here's the knee. So you flex this part, but now you'll feel some resistance here. You are unable to go straight. So that is what is causing so the person is feeling pain, so you're unable to finish. So severe stiffness of the hamstrings. So the hamstrings are here, caused by inability to straighten the leg when the hip is flexed to 90 degrees. Okay, so you won't be able to fully extend this leg. They'll be feeling so much pain. Okay. Understood. Associated neurological signs, impaired consciousness level. So this is how we test using the Glasgow Coma scale. Do you guys know the GCS score? Brian?
Yes.
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 Classify broadly in terms of GCS. What is in terms of
So
levels
we-
of consciousness? Yes.
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 Yes. So we so so we check for motor, for verbal, and for eye movement. And for motor, the highest is 6. For verbal, the highest is 5, and for eye movement, the highest score is 4. So
So-
total is over 15.
Good, good, good. So what is the lowest GCS you can have? Of a dead, what is the GCS of a dead person?
The GCS of a dead person is 3.
3, good. What is the GCS of what are you using to join the class? Laptop, phone, iPad?
My laptop.
What is the GCS of that laptop?
It's let's
That's
say
a
3.
tough question.
Let's say 3.
Yeah, 3. So GCS, they can never be 0. The GCS can never be 0. Okay. So because we know, okay, how I used to remember, I used to say MVE, motor, verbal, eye. So this is very important. You will apply it everywhere, even in psychiatry. MVE, motor, verbal, eye movement, 654. Okay. And we know for 6, maybe I should say a picture because or I'll share on the group. Okay. I'll share on the group so that we follow through. But how to remember, you just know no response in all of them. Motor, verbal, and eye opening is 111. So the GCS must be 3. Okay. Brian, severe brain injury, moderate brain injury, and minor brain injury. What are the scores?
For moderate, I can give it 10.
So it's usually a range. Start with severe.
For severe.
Mm.
For severe brain injury, I can say between 6 to 7 there.
No, you have to start with 3 because see, you have said 3 is no response, so they're dead.
Oh, yes, yes. Oh,
3.
yes, yes.
So I've seen someone has helped in the chat. 3 to 8, yes. So 3 to 8. Then moderate.
9 to 10.
No,
Or
9
to 11.
It's usually 9 to 12. So you're adding 1, 1, 1 in all. So 9, 10, 11, 12. And then 13 to 14 minor. So 15, you're fully conscious. Okay. Are you okay? Or you have a question?
No.
You okay?
Question. Yes, yes, I'm okay.
So focal or generalized seizures are frequent. I think we're going to do a session on seizures. It's very, very high yield, especially in the CNS ward. What is focal seizures? What is generalized seizures? What is petit mal seizures? What is tonic-clonic? What is clonic seizures? All of those. We're going to do that session. Cranial nerve signs occur in 15% of the patients. So if I start asking questions, I don't think we'll finish. But do you know where the cranial nerves arise? Let me pick someone. Margaret. Margaret, are you there?
Yes, I'm there. Yes.
Do you remember where the cranial nerves arise?
I remember it used to arise from different positions along the brainstem. I don't really remember the exact points.
Who remembers? It's very easy. You don't even need to cram. So we know how the brainstem is arranged, isn't it? So we have midbrain, pons, medulla, isn't it? From anterior to posterior, or from cranial to caudal. So midbrain, we have two nuclei, 3 and 4. Cranial nerve 3 and 4. Pons, 5, 6, 7, 8. Medulla, 9, 10, 12. Then cranial nerve 11, which is spinal accessory, arises from the spinal cord. That's how you know it. So, has everyone understood? Or should I write it down? Okay, I'm going too fast, sorry. So, the brain is arranged like this. The midbrain, the pons, and the medulla. So the midbrain, we have nucleus of the cranial nerve 3 and cranial nerve 4. The pons, cranial nerve 5, 6, 7, 8. The medulla, cranial nerve 9, 10, 12. It gets easier for you to remember because when you're doing cranial nerve exam, anytime you tell the patient to remove the tongue, we are testing cranial nerve 9, 10, and 12. So you'll remember all those arise from the medulla. Okay? Then spinal accessory, from the word spinal accessory, it arises from the spinal cord. Okay, whoever's understood, write that down. Write it in the chat. Cranial nerve, we start midbrain, cranial nerve 3 and 4. Pons, 5, 6, 7, 8. Medulla, 9, 10, 12. Spinal cord, 11. So depending, so as you can see, cranial nerve signs occur in 15% of the patient. So it depends. If we get cerebral edema, or the specific part of the brain is affected, let's say the midbrain is affected, we'll expect findings of cranial nerve 3 and 4. Sensory neural deafness, not due to concurrent otitis media, but due to direct cochlear involvement. This is 20%. Focal neurological signs, hemiparesis, dysphagia, hemianopia, papilledema. So hemiparesis, so this is half. Paralysis of half of the body. Dysphagia, this is difficulty in swallowing. Hemianopia, you can't see. Let's say this is your, let me draw. This is your eye. We have, this is half, this is your nose. So this is your nasal side, this is your temporal side. So if you have hemianopia, maybe you can't see from your temporal side. All this is blocked. Then same on the other side. So a patient who has bilateral nasal hemianopia, let me draw like this. Maybe they can't see, let's say temporal. So they'll see tunnel vision. They can only see in the middle. But whatever you do here and here, they can't see. Vice versa, if you are to draw again, let's say they have an issue here at the nasal side, they can only see at the peripheries. They can't see what is happening in between here. That's what you call hemianopia. Papilledema, this is a sign of raised intracranial pressure on fundoscopy. Okay. Okay, let's continue. So non-neurological complications, shock, arthritis. Then we have septic complication, inappropriate secretion of ADH. So SIADH. So here's you have inappropriate secretion of ADH. So meaning you secrete a lot of ADH. And you know the function of ADH in the body is to reabsorb water. Okay. So you'll reabsorb a lot of water in inappropriate secretion of ADH. Acute bacterial endocarditis. So endocarditis. So endo is the inner layer. Carditis. Card, this is the heart. Itis is inflammation. Okay. So here you have bacterial endocarditis, inflammation of the inner layer of the heart, coagulation disorders, thrombocytopenia leading to DIC. So thrombocytopenia, you have low platelets. DIC is where you have the state of bleeding and coagulation. So there is an imbalance in that state. You bleed, then you clot, then your factors are over, you bleed again, then you clot. In that state, that is what is called DIC, disseminated intravascular coagulation. Features specific to causative bacteria, Haemophilus meningitis. Generally occurs in small children. So this was mostly in peds. Meningococcal meningitis and pneumococcal. So these are the two you have to know. We said the pupillary rash, meningococcal, which is Neisseria meningitis. Septicemia can occur with arthralgia. Arthralgia is, so arthralgia. Algia is pain. These are joints, so joint pain with pupillary rash. When overwhelming, confluent, hemorrhages appear in the skin due to DIC. You see why they are playing in the skin? Because you have thrombocytopenia. And you know a feature of thrombocytopenia is petechia and pupilla. Gradual onset, good prognosis. Sudden onset with septicemia, poor outcome. Okay. So if it came 2-3 days, it's acute, or 3, 4, 5 days, that is sudden, can lead to septicemia. It's gradual onset, so maybe weeks, it has good prognosis. Pneumococcal, adult disorder. Often associated with debilitation, e.g. alcoholism, may result from pneumonia, middle ear, sinus infection, or follow splenectomy. Why do you think people get pneumococcal meningitis after splenectomy? Let me see.
Because
okay, yeah, if you know, just answer so that I stop choosing people.
it's a capsulated bacteria. So with splenectomy, you'd have increased risk of getting infection by capsulated bacteria.
Good. So we know the spleen is responsible for filtering encapsulated bacteria. So if you have a splenectomy, you're going to most likely get pneumococcal meningitis. Mortality 20%. Poor prognostic features, coma, seizures, increased protein in, what is that? In CSF. Okay. So we're going to see CSF findings of these specific types of meningitis. Investigations. So we start with CT, stroke MRI. So you have to see CT of the head to see the extent of involvement of the brain. Typically shows thin and linear leptomeningeal enhancement. CSF examination. So we usually do an LP. Now I have a question for you guys. Which comes first? Let's say a patient has come with you complaining of a headache, and you see there's features of increased ICP. Let's say you do fundoscopy, you see papilledema. Which one comes first? Do you do an LP or a CT?
CT.
Why not? Okay, let me phrase the question better. If you don't have increased
LP is
ICP,
contraindicated in ICP.
yeah? Sorry, repeat.
Lumbar puncture is contraindicated when you have ICP.
Yeah. It can lead to brain herniation. So if you see features of ICP, never do an LP. Never. Do not ever try. Funny thing is, we had a viva. So our viva for our day was a stroke. So there's a patient with stroke, and then they had features of increased ICP, and they asked that, what investigation would you do? So someone said, I'd do an LP. Do you know the exam ended there? So the lecturer just told them, oh, you want to kill the patient, have a good day. And the exam ended there. So small things like this can make the lecturers very mad. Very mad if you say anything like that. Never do an LP in a patient with increased ICP. Okay? If they have papilledema, if they have seizures, if they have history of a CNS disease, for example, the stroke, if they have neurological deficits, or if they're unconscious. You can never do an LP. You have to do a CT. Understood? Serological immunological tests, the latex particle agglutination, LA test for detection of bacterial antigen in CSF, then blood cultures. Organisms isolated in 80% are Haemophilus meningitis, pneumococcus, and meningococcus in less than 50% of patients. Then serum electrolytes, important in the view of frequency of inappropriate antidiuretic hormone secretion. Okay, then detect the source of infection. Remember, we said that most common is spread from somewhere. So is it chest X-ray? Was it a pneumonia? Was it a skull X-ray? Was it a fracture? Sinus X-ray, sinusitis. Petrus view for mastoiditis. Management, not very relevant, but this is more of 6th year, but it can come in MCQs. They won't ask you in the words. The management is a 6th year thing, but what you should remember is we usually give vancomycin and a 3rd generation cephalosporin. Then for immunocompromised, we give vancomycin plus ampicillin plus a cephalosporin. Okay, can never go wrong with vancomycin. Steroids, a 4-day regimen of dexamethasone starting before or with the first dose of antibiotics is now recommended in children with Haemophilus and adults with bacterial meningitis, likely to be pneumococcal. But start with antibiotics because we're dealing with the bacteria before you go to steroids. Then prevention. How many slides am I left? Oh, 26, okay. Prevention. Pneumococcal vaccination is now routine childhood immunization and very effective at preventing pneumococcal meningitis. Household members and others in close contact with people who have meningococcal meningitis should receive preventative antibiotics. Okay. There's one case scenario. Okay, not one, but tell me one case scenario where we usually give routine vaccinations to patients. We give them meningococcal vaccines. There's patients with which disease do we give them routine pneumococcal vaccinations?
Sickle cell disease.
Sickle cell disease. Why?
Because they tend to get autosplenectomy, that predisposes them to bacterial infection. Also, the encapsulated bacteria. Yeah, so it's part of the management regimen.
Good. So we know in sickle cell patients, they have sickle cell sequestration, which leads to autosplenectomy, or you can call it functional asplenia. So they have a spleen, but it does not work. So we have to give them routinely pneumococcal and meningococcal vaccination. Viral meningitis. So here I'm going to go really fast. The term aseptic meningitis includes viral meningitis as well as other forms of meningitis, where routine culture reveals no other organisms. So the other one, we called it pyogenic meningitis or bacterial. This one is aseptic meningitis. So etiology, here are the viruses, enteroviruses, mumps, herpes simplex. This is the most common I've had, Epstein-Barr or EBV. Rare ones, lymphocytic, choriomeningitis, HIV, and West Nile virus. Enterovirus, these are in children. Mumps, these are in children. Relevant to us is herpes simplex and HIV. But for HIV, it rarely causes meningitis on its own. What happens is you're immunocompromised, then you usually get cryptococcus meningitis. Transmission, so spread through the bloodstream from an infection from another part of the body. Contact with contaminated stool, so these are the enteroviruses. The enteroviruses are like the polio. Sexual intercourse, HSV2 and HIV. Insects, West Nile virus, spread through the air, HHV3 or varicella zoster. Contact with dust, food contaminated. Then needles like HIV. Clinical, usually similar, fever, malaise, sore throat. These are the prodromal before you get the meningitis. Then meningeal headache, photophobia, drowsiness, neck stiffness. It's usually self-limiting. You recover in 7 to 14 days. Signs, mild meningism, neck stiffness, scanning positive, no focal signs. Okay, you can tell the difference. So here you won't have focal signs, so the signs of increased ICP. Then skin rashes, parotitis. So this is parotid gland. And then diarrhea, myalgia may or may not be present. Complications, febrile seizures, mostly in children. Then SIADH. Investigations will do the same, but here we are specific to what you're looking for. CSF. Okay, CSF findings, I'll get to that. Then PCR for DNA, viral DNA in CSF. Virus may be cultured from throat swabs or stool. Serological tests on serum in acute convalescent states, especially valuable in detecting mumps and herpes. Then differential diagnosis, tuberculosis or fungal meningitis, leptospirosis, sarcoidosis, carcinomatous meningitis, partially treated bacterial meningitis, parameningeal chronic infection, which evokes a meningeal response, e.g. mastoiditis. So all these differential diagnoses are what you're supposed to rule out in your history. Sarcoidosis is very easy to rule it out. It's an, this is multisystemic. So, and it's autoimmune. So you'll expect things like skin rashes, joint pain, features of hypercalcemia. Okay. So this one, it'll be easy to rule them out. Then leptospira, this is another bacteria, tuberculosis or fungal meningitis. So tuberculosis, anything with TB, you have to rule out the B symptoms. Then fungal, we're talking about immunocompromised individuals. Then treatment, so treatment for viral meningitis, usually supportive, and we said it's self-limiting, so rest, hydration, antipyretics for the headaches, antipyretics for the fever, then pain medication, NSAIDs, then prognosis is excellent. So while I finish, I want to, I realized I hadn't attached let me send it to the group. So this is very, very high yield. CSF findings in meningitis, very, very high yield. You have to know this. So we start. Normal opening pressure is less than 200. Okay, in any form of meningitis, the opening pressure will be more than 200, as you can see, bacterial, viral, fungal, or tuberculous. WBC count, the normal is 5 WBCs, 70% are lymphocytes, 30% monocytes, very few neutrophils, very few. Protein level, 15 to 20. Glucose level, 45 to 100, or 2/3 of that of serum. Then glucose CSF ratio is usually less than 0.4. Now, let's start with bacterial, which is the most common. Opening pressure will be more than 200. WBC count, a lot, because the body is fighting the infection. But what is very keen with bacterial that you must know is that they have neutrophilic pleocytosis, meaning that the level of neutrophils are very, very high, more than 80%. Protein level, you'll observe, very high. Protein levels, very, very high. Okay. The protein levels will be very, very high, but the glucose levels are low. This is because the bacteria is using the glucose for metabolism. Have you understood for bacteria? So if you see a picture in exam where we told opening pressure was maybe 250, neutrophils was 80%, protein was 500, glucose was, let's say, 20, you'll have the picture of bacterial. Viral, similar to bacterial, opening pressure is 200. WBC count, a lot, but not compared to bacterial. And here we have lymphocyte pleocytosis, okay? So the main cell is the lymphocytes. Protein level will be high, but not as high as the bacteria. Then the glucose level will be normal. Okay. Fungal, similar to the rest, opening pressure is 200. WBC count, not as much as bacterial. Here we have mononuclear. pleocytosis. Protein levels 15 to 200, glucose levels less than 40, so it will be low. Tuberculous, similar to fungal, but here we have lymphocytosis, okay? 100 WBCs, increased protein level, but not as, so it's tuberculous. So we know TB is also a bacteria, but the main cell is mononuclear pleocytosis, which is lymphocytosis. So protein is expected to be high, glucose is low. So this table, you have to know it at the back of your arms. Anytime you're asked, just, if you know bacterial, you can work your way. Just know bacterial will have increased WBC count. Neutrophils are what is most affected. They'll be very high. Protein is high, glucose is low. Then the rest you can get. Okay, any question?
Could you kindly comment on the color you get on the CSF sample?
Yes. So for the color, we said bacterial is cloudy. Be very, very cloudy. Okay. Viral usually clear. Fungal and tuberculous, I'm not sure, but what you have to remember is bacterial is cloudy. If you see cloudy, those are, you will know that this is bacterial. Okay. Any other question? You can start.
So the patient is Elijah Mwaura, a 19-year-old male from Makadara. Was born and raised in Nyahururu, finished high school last year and is yet to join university. Was admitted to Kenyatta Hospital 5 days ago. As of the day we clerked, which was 9th October.